respiratory chain defects. Another word or another term for the respiratory chain is the electron transport chain. And so here is sort of a brief overview of what we're going to be talking about. We know that there's clearly an interaction between carbohydrate and lipid in terms of their metabolism. And so we have fatty acids that are then activated and internalized into the mitochondria for fatty acid oxidation. And the same is true for glucose. Glycolysis goes to pyruvate, production of acetyl-CoA in the mitochondria. And that can go to the TCA cycle, and this can move on in what's called anaerobic glycolysis. But fatty acid oxidation is something that requires oxygen, in that it leads to the production of NADH and then enters the electron transport chain, and then through a process of oxidative metabolic processes, ATP is produced. In the end, we're interested in producing ATP because that is the source of energy that is derived, certainly in large part, from lipid metabolism. What is the electron transport chain? It's a collection of proteins that are bound to the inner mitochondrial membrane, and electrons pass through a series of oxidative, reoxidative, and reduced reactions called redox, and release energy. Now, this is just another slide showing you the same thing I showed you. The citric acid cycle shown here, the Krebs cycle, while it produces energy, for each cycle produces 2 ATPs. Why is fat such a potent producer of energy? Well, when fat enters the electron transport chain, when acetyl-CoA enters the electron transport chain, for each cycle it produces 34 ATP. Now, the problem, of course, occurs when we have to rely only on carbohydrate breakdown, glycolysis for energy. We rapidly run out of energy. And if we can't metabolize fat, we saw in the last lecture the problems that arise. When there's dysfunction in the respiratory or electron transport chain, we get a decreased production of ATP. If you have low ATP, low energy produced from fatty acids, you upregulate anaerobic glycolysis, which leads to an overproduction of pyruvate. Now, pyruvate can be transaminated to alanine or reduced to form lactate. And so in most of these disorders, what you get is an elevation in serum lactate. That is, we showed it on the last lecture. It's the same with these respiratory chain defects. We have an overproduction of pyruvate leading to an overproduction of lactate. So there are more than 40 known types of these respiratory chain disorders. They're very difficult to identify. They can be mild or severe, and many of them may never be identified during life. They can begin at birth or present in adulthood, and the overall, if we go through all of the respiratory chain disorders, it's 1 in 25 to 4,000 live births, which is only a predictive value. We don't know for sure. So what do we know about the mitochondria that we haven't learned before? Well, the mitochondria has a separate genome, and that genome comes from the unfertilized ovum. It's maternally transmitted. It's a double-stranded circular DNA with about 16,000 base pairs, and it codes 37 genes. Now, this mitochondrial DNA is dependent on genes from the nucleus for enzymes of replication, transcription, or translation repair. And therein lies the conundrum that we're faced with mitochondrial disorders. Is it derived from mitochondrial DNA mutations or nuclear DNA mutations? Because many subunits of the respiratory chain are encoded by nuclear DNA and then imported into the mitochondria. Now, these two genomes coordinate and communicate, And here we see the various components of the mitochondrial DNA. There are complex 1, 2, 3, 4, 5, and you see at the top which each of these complexes stand for. However, if you go further into the genome, you see that some of the genome, with the exception of complex 2, comprises mitochondrial DNA, and one of them, complex 2, comprises nuclear encoded DNA, and all of the complexes contain nuclear DNA. And down at the bottom, you see exactly the distribution between nuclear and mitochondrial encoded DNA in the various respiratory chain or electron transport chain complexes. So this mitochondrial DNA is very susceptible to mutation, and it mutates 10 to 20 times more frequently than nuclear DNA. However, nuclear DNA is associated with protective molecules called histones, and there also is an effective repair system. And this histone protection or repair system is absent from mitochondrial DNA. So we all have mitochondrial DNA that is mutated in our bodies to some degree or another. The mitochondrial DNA is constantly exposed to reactive oxygen species from the process of oxidative phosphorylation, and mutations in mitochondrial DNA only account for 10 to 20% of mitochondrial respiratory chain disorders. So even though you get everything from the mother, even though this mitochondrial DNA is readily mutated, mitochondrial respiratory chain disorders that are the consequence of mitochondrial DNA mutation specifically are relatively uncommon. Defective nuclear genes result in a low synthesis of all mitochondrial DNA. These are called depletion syndromes, and these are the most common category of these mitochondrial disorders. Each mitochondria contains 2 to 10 copies of mitochondrial DNA. Why so many copies? Again, because they tend to mutate. And these normal and mutant mitochondrial DNA can coexist in various proportions in a single cell and be associated with normal functioning. These mitochondria are randomly partitioned during cell division. While the mutated and the native mitochondrial DNA can exist together, there is a threshold for mutated mitochondrial DNA that would lead to a phenotypic expression of a disorder. And because this is highly variable, it accounts for the variability in clinical presentation. The same genotype can present at different ages depending upon the amount of mitochondrial DNA which is mutated. So again, it's a very, very complex, a very, very complicated heritability. What you really need to know is that we all contain mutated DNA, and under the vast majority of conditions, that amount of mutated mitochondrial DNA is insufficient to cause a phenotypic expression of disease. And here is just a view of the pedigree of mitochondrial inheritance. As you can see, when the male is affected, there's no transmission of mitochondrial DNA mutation. When the female is affected, when the mother is affected, all of your offspring are going to contain that mitochondrial DNA mutation. So inheritance is only through maternal lines. Affected males do not pass on the genes. But remember, most of these mitochondrial respiratory chain disorders are a consequence not of a mitochondrial mutation, but of a nuclear DNA mutation, that nuclear DNA moiety, which interacts with your mitochondrial DNA. As I said, it's not that simple because mitochondrial diseases can Again, maternal inheritance, relatively uncommon. They can be sporadic, which means no genomic cause, or they can be autosomal recessive. These autosomal recessive mutations are where nuclear DNA mutations affect mitochondrial DNA. That's the most common etiology of these respiratory chain disorders. The autosomal recessive, not dependent upon mutations in mitochondrial DNA, but dependent upon mutations in nuclear DNA from a haploinsufficient parent, or two haploinsufficient parents. So let's look at the genetics of mitochondrial pathobiology. Normal mitochondrial protein translation is mainly coded by nuclear genes. Abnormal mitochondrial protein translation can be due to mutant mitochondrial DNA, but less common, transfer DNA, or due to DNA mutations in the nucleus that determines the amount of mitochondrial DNA and the assembly of respiratory chain components. That's the most important. The most important etiopathogenesis of these mitochondrial respiratory chain disorders are mutations in nuclear DNA that determine the amount or the assembly of respiratory chain components, the amount of mitochondrial DNA or the assembly of the resulting respiratory chain components. Now, there are a variety of nuclear gene classes that affect mitochondrial DNA. The most important for you to know about is POLG. That is the nuclear gene which is responsible for the Alpers-Huttenlocher syndrome that I've talked about endlessly in the past, and we'll talk about again. And then there's MPV17, DGWAC, Twinkle, TP. These are all things you should read about, but that's, of all of them, the POLG is likely to be the only one on the boards. And these nuclear gene classes affect translation of mitochondrial DNA, and if these nuclear genes affect the assembly of mitochondrial DNA. The clinical features are widely varied. Some of them are shown here. MELAS syndrome, MRF, Leber hereditary optic neuropathy, external ophthalmoplegia, neurogenic weakness, ataxia, and retinitis pigmentosa. Why so variable? Well, because all of our organs and tissues contain mitochondria, and depending upon where the mutations are expressed, that's going to determine the phenotype as well as the severity of the resultant disease. Again, it can affect any system. It's shown here. And so, again, we're not going to go over this in detail. I showed you at the beginning of the lecture the seminars in liver disease from 2007. That remains, I think, the outstanding review article of its type. And it'd be worthwhile for you to go and read it because it'll give you some familiarity. You read this once, you'll see it on the boards, you'll recognize it. So I mentioned that the clinical features and age of presentation of the primary mitochondrial hepatopathies are extraordinarily variable. It can present in the neonatal period, during infancy, during childhood, and during adulthood. The Alpers syndrome, shown all the way to the right and on the bottom, is the one that's associated with profound sensitivity to toxicity from valproate, tends to present during childhood. And then, excuse me one second, I have a personal thing I'm dealing with. I'm sorry. Oh, please. And then we have the mitochondrial depletion syndrome. It can present in the neonatal period with cataracts and nystagmus. Pearson syndrome leading to pancreatic insufficiency is a mitochondrial disorder. And then we have Navajo neurohepatopathy, which again occurs between infancy and childhood. So it's tremendously variable. Again, the most important one for you to know about, and you should read something about, is the Alpers syndrome. So, mitochondrial disorders, in the end, are disorders of energy metabolism, and they can lead to liver failure. Again, I can't emphasize too much the importance of POLG, which stands for mitochondrial DNA polymerase subunit gamma. That is associated with Halpers-Huttenlocher syndrome. Navajo hepatopathy is another one. Relatively, of course, because it's Navajo, it was first described in the Navajo population and is the most common congenital form of mitochondrial disorder in that population. Dr. Binowitz, who's not on the call, and I used to see a lot of patients with Rye syndrome. Something else you should read about Rye syndrome, in the end, is a mitochondrial disorder caused by the interaction of salicylate, which induces reactive oxygen species in the mitochondrial respiratory chain in patients who are under stress from a variety of infectious causes, the most common being varicella. There are secondary mitochondrial hepatopathies. Wilson disease is a mitochondrial hepatopathy. Metabolic associated steatohepatitis, which I haven't changed in this slide, from NASH, is another one, which essentially reflects disorders in the mitochondria. Of course, this is secondary to another problem or disorder as well. And of course, valproate can induce a mitochondrial hepatopathy. Valproate, of course, again, is what is especially important in patients with Alpers because it can cause acute liver failure in that group of patients. So the overall prevalence of these mitochondrial diseases is quite rare. Mitochondrial DNA mutations in the UK, 7 per 100,000. In Finland, 1 in 100,000. Again, these are very rare disorders, but only about 20% of them are associated with liver disease. The consequences of respiratory chain dysfunction are what you would expect: a deficit in cellular energy, an increased dependence on glycolysis with increased lactate production, reactive oxygen species being increased, impaired TCA cycle, impaired beta oxidation, and it could also affect the opening of mitochondrial pores, which allow for the release of cytochrome C and certain factors that can lead to cell death. What about liver biopsy findings? As again you might expect, because this are going to be again in the end a disorder of fat metabolism, steatosis. So steatosis, this is happens to be a child with a mitochondrial DNA depletion syndrome. This is the Alpers-Huttenlocher. Steatosis is an almost universal finding. It can either be micro or macro steatosis. If you do a biopsy on a suspected patient and there is not an accumulation of fat, it's unlikely this patient has a mitochondrial respiratory chain disorder. This is a normal mitochondria. You can see the outer and inner mitochondrial membrane, as well as the invaginations, the membranes within the mitochondria. These are known as the cristae. This is where all the metabolic processes take place. And this is the mitochondria of a patient with Alpers-Huttenlocher syndrome. You can see the outer and inner mitochondrial membrane, but what's inside the mitochondria? There ain't nothing at all. Again, this is a significant mutation which causes mitochondrial depletion or deletion, and there's a total absence of the normal histopathology in these patients. So we can classify the primary mitochondrial hepatopathies in a number of ways. There's neonatal liver failure, which is generally the result of a depletion of one of the main respiratory chain complexes that I showed you earlier. Then there is the mitochondrial depletion syndrome, which includes the patients with delayed onset liver failure or Alpers-Huttenlocher. The delayed liver failure in the Alpers patients is often the consequence of giving them valproate because these patients have seizures. And if they have seizures and their diagnosis hasn't been confirmed, that may lead invariably to liver failure. The Pearson marrow-pancreas syndrome, and finally, the Navajo neurohepatopathy. I would encourage you to read about Navajo neurohepatopathy, Pearson syndrome, and Alpers-Huttenlocher. Those are the three major ones which are likely, if any of them, to appear on the boards. The mitochondrial DNA depletion syndrome, in order to have that be phenotypically apparent, you have to have less than 10% of the amount of normal mitochondrial DNA to DNA ratio in affected tissues. Generally, there's a normal mitochondrial genome sequence. There's just not enough of it, which leads to an insufficient synthesis of the major respiratory chain complexes. Remember, respiratory chain complex number 2 is all nuclear, so it would not be expected to be deficient in the depletion syndrome. And then it can be myopathic or hepatocerebral with a variety of clinical symptoms. The genes responsible for the mitochondrial depletion syndrome, 80% we don't know. When studied in experimental yeast samples, there are more than 100 different genes in the yeast that can cause mitochondrial DNA loss when mutated. For the 20% that we are able to identify, here are the variety. Remember I told you about DGWAT, that's deoxyguanine kinase, thymidine kinase, and a variety of other mutations which can lead to the clinical syndromes. If we're going to look at the hepatic and extrahepatic features, again, we talked about neonatal liver failure, the poorly described, poorly delineated overall mitochondrial depletion syndrome, which leads to early neonatal progressive liver failure. And again, this has to be differentiated from neonatal iron storage disease. Again, the most common one that we would see, I've only seen 1 or 2 cases in my career, is Alpers-Huttenlocher. The onset is insidious. This presents in children and young adults. And generally in the Alpers syndrome, it's a pure hepatopathy with hepatomegaly, jaundice, transaminasemia, cirrhosis, and progressive liver failure. Pearson's, again, insidious onset, can present in infancy, and this is where you get pancreatic insufficiency and associated with liver disorders. And then a variety of others down at the bottom, the Navajo neurohepatopathy, which presents as a Rye-like syndrome. You should review Rye syndrome. It's doubtful that it's going to appear on the boards, but it has in the past. Should probably ask Dr. Levine, since he's taken the boards most recently, whether there were any questions on Rye syndrome. When I was in training and when I first took the boards, was Rye syndrome all over the place because it was really the most common cause of hepatic dysfunction that in the acute case scenario that we would see when I was a resident and a fellow. Navajo neurohepatopathy is something that's worth talking about. And one of my close friends, Amit Shub, who's out in Phoenix, not surprisingly, was in the vanguard of investigators who first described this. It's an autosomal recessive. Remember, most of these disorders that cause mitochondrial depletion are nuclear gene mutations, and they're autosomal recessive, as is Navajo neurohepatopathy. It's another mitochondrial depletion syndrome with reduced activity in all complexes because it's a nuclear problem. It has a mutation in MPV17, which is a nuclear gene that encodes for the mitochondrial intermembrane protein. There are various types: liver failure in infancy, slowly progressive liver disease, peripheral neuropathy, and there also can be progressive white matter lesions. So again, it affects multiple organ systems, most commonly the liver and the CNS. MPV17 is another one. Again, very few patients described consanguinity in 2 out of 3, a variety of disorders. Again, this is just a laundry list of disorders that you will come across. But again, if you see MPV17, it's another a mitochondrial depletion syndrome, another one that encodes for the mitochondrial intermembrane protein. You will note that both this and that, Navajo neurohepatopathy, both involve genes that encode the mitochondrial intermembrane protein. And wherein lies the conundrum that we face, because you can have similar mutations that cause vastly different phenotypic expression. Here's another one. This is another mitochondrial depletion where the mitochondrial DNA is 5%. And again, you get here liver and renal findings. Again, wildly variable, even though the basic mechanism, that is nuclear DNA mutation, which is coding for an insufficient amount of mitochondrial DNA, causes an absence of mitochondrial DNA, leading to the respiratory chain disorders that we've reviewed. This is DGWOC, again, presents in the postnatal period, rapidly progressive liver failure. This is another one. The diagnosis is confirmed by respiratory chain activity and mitochondrial DNA levels. Hello, another mitochondrial depletion syndrome. And finally, the one that you really do need to know about, we'll spend a little more time, that's the Alpers-Huttenlocher syndrome. Again, an autosomal recessive caused by mutation of the POLG gene that leads to delayed onset liver disease with the onset between 2 months and 8 years, a number of nonspecific findings, and the liver biopsy can be confused with metabolic associated steatotic liver disease. Laura, I'm in the middle of the lecture. I'll have to call you back. And also leads to mitochondrial cirrhosis. These patients have progressive psychomotor regression. And again, they will have elevated lactate, as many of disorders will, and valproate. So again, patient presents with seizures, is given valproate, rapidly goes into liver failure. This is going to be the problem. And that would likely be the clinical scenario that you would see on the boards relative to these mitochondrial respiratory chain disorders. This is a 3-month-old child with a POLG mutation, the Alpers syndrome. And as you can see here, microvesicular steatosis. Here's the oil red O stain. And here's the EM showing the small lipid vesicles. Again, here's the reference for you. As in all of these mitochondrial respiratory chain disorders, the typical histopathologic finding, aside from cirrhosis, is going to be steatosis. The Pearson marrow pancreas syndrome, again, these are patients that have blood cell dyscrasias with macrocytic anemia, neutropenia, thrombocytopenia. They develop signs of pancreatic insufficiency during the first year of life. They also have marked hepatomegaly. They may die of liver failure in the first decade of life, and they will have, again, a variety phenotypic problems. This is the Pearson-Maropancreas syndrome. Again, it's one of these pancreatic insufficiency syndromes you need to know something about. So, what are the nonspecific clues that you can use to identify mitochondrial hepatopathies? Patients presenting with mild to moderate hepatomegaly, patients presenting with hypoglycemia. Remember, they may be hypoglycemic because of their over-reliance on anaerobic glycolysis in the TCA cycle, so they deplete their glycogen stores. Failure to thrive, feeding difficulties. They will have elevated transaminases, usually less than 10 times the upper limit of normal. And they can have episodic decompensation provoked by infection. The same as we saw for the fatty acid oxidation disorders. When they're fasting or under stress, they're unable to keep up with their energy demands. And then, of course, steatosis, which can be identified on imaging studied or on biopsy. And that may rapidly progress to cholestasis. So anytime you have any of this constellation of symptoms, at least consider the possibility of a respiratory chain disorder. Again, the diagnosis is dependent on a constellation of organ involvement rather than the sequence. Some patients may have normal early development. Liver involvement can be variable. Later on, seizure disorders may be evident. One of the things to remember for the vast majority of these patients, one makes the diagnosis of liver failure related to a respiratory chain disorder. Liver transplant is relatively contraindicated because these are systemic disorders. And if one does liver transplant, that's likely to recur. And secondly, it's not going to correct the disorders in other systems. Very variable, a variety of sequences, and the most important thing is having an index of suspicion. The laboratory features, if you suspect a mitochondrial hepatopathy, if it's neonatal or infantile onset, to the left, you see here the depletion syndromes, which are the most common. All right. In the end, they all have lactic acidosis. They all have lactic acidosis. So again, anyone presenting with any one of these constellation of syndromes, get a serum lactate dehydrogenase levels. If the LDH is very, very elevated, you know in what direction to go. For the variable ones, that could be more difficult. And again, but most of these also are going to present with lactic acidosis. So just like you saw with the fatty acid oxidation disorders, an elevation in serum lactate, a marked elevation in your lactate dehydrogenase gives you the clue to further evaluate. And again, here's our friend, the POLG disorder. Again, valproate-induced liver failure. You're likely not going to see this patient until this patient presents with liver failure. Again, the screening, I can't emphasize too much, is a persistent elevation in your plasma lactase, an increase in the molar ratio of lactate to pyruvate, and the ketone body ratio, you get more 3-hydroxybutyrate compared to acetate. A paradoxical increase in plasma ketones or lactate after meals. Remember, after meals, you should have a reduction, but you can get a paroxysmal increase or paradoxical increase in ketones after meals. You can then give them an oral glucose load and look for elevations in plasma lactate, and then a variety of laboratory signs. Dysfunction in the electron transport chain causes a decreased production of ATP. These low ATP levels result in an upregulation of anaerobic glycolysis, so you get an overproduction of pyruvate. I showed you that very early on. And that pyruvate can be transaminated to alanine, or more commonly in these disorders, reduced to form lactate. And that's why you get an elevated lactate. So again, this is just a review. These are the tools for the study of these disorders. You're unlikely to come into contact with any of them. If you do, the POLG would be the most common. Again, you can do screening for mitochondrial as well as nuclear DNA mutations, which can be used to, in case of nuclear DNA mutations, to identify specific variances of these mitochondrial depletion syndromes. What about liver biopsy? Again, it depends upon whether the patient is in liver failure. If they're not, then it certainly is indicated. Of course, in other patients, you have to be worried about coagulopathy. And the findings routinely are micro and macrovesicular steatosis, reduced glycogen, abnormal mitochondria. So all of these patients should have EM done on them, and a variety of histopathological abnormalities. So when doing a biopsy in these patients, we should always, A, do a routine staining, 2, get a specimen in glutaraldehyde for EM, and if possible, snap freeze, if not in liquid nitrogen, then at least in dry ice and acetone, so you can get the enzymatic analysis. There are proposed medical treatments for mitochondrial respiratory chain disorders. These are largely antioxidant cocktails, and this is called TPGS, and contains coenzyme Q and a variety of compounds, which are, again, directed at alleviating some of the difficulties. And you can see here, one of them is dichloroacetate, which is used to upregulate the conversion of pyruvate into acetyl-CoA so that it goes into the TCA cycle and doesn't go on to lactate. As you can see here, pyruvate wants to go to lactate in these disorders, but by giving a dichloroacetate, the hope is that you can push the reaction towards acetyl-CoA. In truth, this cocktail, which is an antioxidant cocktail, is theoretically of use, but in clinical practice probably does very little for most of these patients. What about transplantation? As I mentioned, you have to exclude brain, muscle, cardiac, renal, and hematologic involvement. There have been liver transplants in the literature, about 30 patients, 17 with a known mitochondrial respiratory chain disorder. Up to 24 months post-transplant, half of them died. As you know, the overall 2-year survival is close to 100% for liver transplant. So this is why this is relative contraindication. Of the 16 survivors, 2 of them had significant developmental delay. So again, we're talking about over half of these patients either with a resultant death or with an unsatisfactory postoperative clinical scenario. Again, it's a relative contraindication. And so when considering a mitochondrial hepatopathy, it's important to evaluate the heart, the CNS, the respiratory system, the endocrine. Again, pancreatic insufficiency is part of the Pearson syndrome as well. Depending upon which mitochondrial disorder you're looking at, you can have a variety of neurological presentations. It suffice it to say that most of these patients will present with some aspect of developmental delay, psychomotor delay, developmental disability, and of course, refractory seizures, which are characteristic of the Alpers-Huttenlocher syndrome. So what do you have to remember? Remember that mitochondrial disorders are the consequence of heteroplasmy, which means the presence of more than one type of organelle or genome within a cell or individual. You must remember that you are examining both mitochondrial and nuclear DNA, but for the majority of these respiratory chain disorders, the abnormality is in the nuclear DNA and the inheritance is autosomal recessive. We can have mitochondrial DNA deletions, depletions, or mutations. Again, the depletion syndromes in the middle are the most common. This involves the electron transport chain and oxidative phosphorylation. Patients invariably present with lactic acidosis, high evidence of serum lactate and LDH levels. Valproate is a no-no in patients with an undiagnosed seizure disorder where the idiopathogenesis is unknown because of the possibility of Alpers-Huttenlocher syndrome. So if you have a patient presenting with seizures, check their liver first before you start giving them valproate. And finally, the histopathologic characteristic is that of metabolic-associated steatotic liver disease. And when you see a patient with MASLD, one of the things you need to consider is whether this is diet-related, whether this is related to some other genetic factors, as we discussed when we discussed MASLD specifically, or whether this is the consequence of a mitochondrial hepatopathy. And with that, we're done.
Thank you.
Thank you.
Okay.
Thanks, Steve.
Thank you, Dr. Schwarz.
Hey, Tom, what's going on?
Yeah, I'm good.
I
We're
have a question for you guys.
Go ahead.
Unrelated to today's lecture, but I was curious if a neonate is getting phototherapy for indirect hyperbilirubinemia at day 2 or 3 of life with an initial bilirubin of say like 16.5 and a direct of 0.7. If 24 hours later they get a repeat bili, is it normal to expect the direct bili to rise after phototherapy?
Yes,
Okay.
yes, because what's happening is you have first of all, do you expect it to rise? No, you don't.
Well, depends when.
It depends when. I mean, again, keep in mind that when I showed you this, it's a very interesting question. If you look at patients with biliary atresia and you do their bilirubin measure bilirubin within the first 72 hours of life, patients who end up with bilirubin with biliary atresia are going to have a mild elevation in direct bilirubin.
Sure.
Remember, the patients who are hyperbilirubinemic have a high bilirubin load.
Right.
The liver.
I mean, I think the
liver's conjugation. You present with load. You might have a mild increase in direct bilirubin, but it shouldn't be pathologic. It shouldn't be greater than 1.
It depends on how much. A slight increase
So
would make sense
0.7
because
to
you're
2.3.
physiologically, huh?
So 0.7 to 2.3.
No, that's a problem.
That's problem.
And then it came down to on repeat. It came because they did phototherapy, there's some more phototherapy, and it came down to 1.7. But that's a problem.
Again, that's a problem. It's always about the raw direct. It's not. I mean, the trend doesn't matter as much as the raw number, and that is a problematic raw number, even in that context, and bears a little bit of monitoring.
The best way to look at this is for a total bilirubin less than 5. Less than 5. We're talking about any direct bilirubin greater than 1.
Right.
If it's greater than 5, then it's 20% of the total.
Yeah.
If it's 16,
20%.
if it's 16 over 2, that bears watching but is still within the range that we would not say, oh, yes, this patient's going to have biliary atresia. So what you do with that patient is you bring them back. Certainly, you want to check them again in 2 weeks, if not before.
Yeah. Any patient, honestly, who gets above 2 in a direct, you should be evaluating to make sure it resolves. There's basically no justification that should make you comfortable with that.
Okay. So in a week's time.
Yeah, like you don't need to immediately biopsy based off of that story, but you should definitely be checking again. And then, what's the time horizon? When do you want to have your biopsy? And that's assuming, I don't know what Yale's Kasai situation is, but when do you want to have the biopsy?
Maximum like 4 to 6 weeks, right? Because we want to get it done before the 6-week mark.
You want, if you get a patient, when I was in training, it was 10 weeks. Then it went down to 8 weeks. Then it went down to 6 weeks. Now it's down to 4 weeks.
Well, there's a lot of debate about that. There's an argument about biopsying too early. What's the problem with biliary atresia if you biopsy too early?
It's not.
You're not going to see the proliferation.
There's no atresia.
You're not going to see.
You're just going to see normal bile ducts and a pissed off liver.
I once saw a patient for second opinion who had a Kasai procedure for alpha-1 antitrypsin deficiency. Although they didn't know it was alpha-1 antitrypsin.
Yeah. So what this buys you is
Dr.
the evaluation.
Khan, what would you do? What was the first thing you should do in this patient if you were in a good pediatric center with all of the ancillary services that you need?
So first thing I would do is obviously I'm the gastroenterologist. So if I were general peds, I would refer to a gastroenterologist. But if I'm seeing this patient as a gastroenterologist, I would get surgery on board, potentially.
Don't ask a surgeon for an opinion. You only ask a surgeon to cut.
I would, involve hepatology.
What lab did you say?
You are a hepatologist.
Okay. What labs? So he's asking what your evaluation would be.
So I would get labs. So I would start off with getting a full set of LFTs.
What's your most important LFT?
My most important LFT is
aside from the
direct bilirubin and
indirect
GGT.
You can only get one. Which one is it? GGT. All right. GGT is elevated.
If GGT is elevated, then that rules because
it's
low
actually
GGT,
more useful if GGT is normal.
So GGTs are elevated in all newborns. So if the GGT is normal, that's reassuring. If the GGT is elevated, that doesn't mean you got a problem.
I would actually say if you have a kid with cholestasis and a normal GGT, it would freak me out a little bit for one of the 2 GGT normal causes of cholestasis.
So if you get a GGT
synthesis defects,
you get a GGT, it's elevated. What's the next thing you're going to do?
So the next thing that I'm going to do is
check
I'm going to
the
get
reference
an MMP7.
range for normal GGT in infants. The lab
It's above 150.
So I know, but you have to check your reference ranges and check against your lab because it's not going to be right based on the flag.
What's the next thing you're going to do?
I would potentially get an MMP7.
You want to get involved in that fight with all the hepatologists and their arguments about MMP7?
Much simpler than that.
What labs are you going to send as part of your initial evaluation for a newborn with cholestasis?
So, of course, I'm going to send for alpha-1 antitrypsin.
What kind of lab for alpha-1 antitrypsin?
So, you send the...
Because if you just write in alpha-1 antitrypsin into the EMR, you'll get
phenotype. The phenotype.
Before your alpha-1 antitrypsin is going to come back in 2 weeks with pi typing. All right? So, what are you going to get?
Cholestasis panel.
Forget the cholestasis panel. You know the baby's cholestatic, got direct hyperbilirubinemia.
Right.
You're going to get an ultrasound.
Right, an ultrasound, of course.
Well, I kind of want to go through the whole package. So yes, you're going to get an ultrasound. You're going to get the A1AT PI type.
What are you going to ask the ultrasonographer? Are you just going to send an ultrasound, or are you going to give instructions to the ultrasonographer?
To check for portal flow?
You definitely want to check portal flow, but that's not the main thing. What are the signs on ultrasound?
I lectured on this 6 times out of nowhere.
If you're looking for biliary atresia, what are the signs on ultrasound?
Oh, like bile duct proliferation? You wouldn't see
You're
that.
You're not going to see bile duct proliferation
on ultrasound. That'd be a very impressive ultrasound.
Bryce, get in here. What are you going to ask for? All right. I'm not going to belabor